Welcome to Beyond the Mask. Today we're stepping into the heat of a clinical debate. Direct laryngoscopy or video laryngoscopy? What should be the standard? On one side, the tried and true direct laryngoscope, reliable, durable, and time-tested. On the other, the modern marvel of video laryngoscopy, a technology that's transforming how we see and secure the airway. But is one truly better than the other? Are we trading skills for screens, or are we embracing progress that saves lives? In this episode, we'll explore the evidence, the experiences, and the strong opinions behind this debate. You'll hear from seasoned providers on both sides, talk training, trauma, and tech, and we won't shy away from the tough questions.
CRNA Financial Planning is a sponsor of Beyond the Mask podcast. Investment advice offered through Private Advisor Group. Nothing in this podcast should be construed as investment advice. Plus, did you know listening to our podcast can earn you Class B credits? For details on how to submit, visit the CE credit section at beyondthemaskpodcast.com. Welcome to Beyond the Mask, innovation and opportunities for CRNAs and advanced practice nurses, with certified financial planner Jeremy Stanley and CRNA Sharon Pierce. Jeremy Stanley has worked with CRNAs for more than 23 years, and Sharon Pierce is a former president of the AANA and the NCANA. Join us as we leave the operating room and learn the latest in the CRNA and advanced practice nurse industries. Beyond the Mask starts in 10, 9, 8, 7.
Try saying direct laryngoscopy, video
direct
laryngoscopy,
video laryngoscopy. I'm glad you said that.
It's a tongue tweezer.
Oh my God. Maybe I should have let you read this.
That would have been great. Hey, Laura, I haven't introduced you, but how do you say Hermes?
Hermes.
You lose.
Dang it.
You really went after her about that word? Like you knew how to say it better?
No.
What do you say? Hermes?
Hermes.
Oh,
He called Dan Lovenera dog Hermes.
No, Hermes.
Hermes. Yes, Hermes. Yes. I learned. We all learn, right?
Every day's learning.
You learned all right.
All right. So everybody's heard from Laura so far, but let's hear from Karen. Welcome to the show, Karen.
Thank you.
Tell everybody about you and your background.
Well, I am from the University of Pittsburgh Medical Center in Pittsburgh, Pennsylvania, and I spent almost 14 years doing mostly ENT surgery. So spent a lot of time with laryngologists, taking care of patients with all sorts of laryngeal and vocal cord issues, vocal cord paralysis, unilateral, bilateral, temporary, permanent, stenosis, subglottic stenosis, lesions. And I've seen a lot of patients come in with intubation and laryngoscopy injuries like arytenoid dislocations, lacerations, tissue tears, and seeing how life-changing that is, which brought me to work with Laura on video laryngoscopy.
Wonderful. And Laura Ardizzone, welcome back to the show.
Thank you.
And Laura's actually going to help me co-host on a couple of episodes, so it's going to be fun. So we got to get used to this going back and forth a little bit, Laura.
Absolutely.
Right? So,
You got to learn how to give him a hard time when I'm not here,
that's right.
Laura.
Yeah,
That's my number
big
one
shoes
job.
to fill. You know what I mean? So tell our listeners a little bit about you.
Sure. My name is Laura Ardizzone. I'm currently the director of anesthesia services at Memorial Sloan Kettering Cancer Center in New York City. I have a team of about 160 CRNAs, and we deliver oncology services to patients across the lifespan.
Wonderful. Wonderful. So the great debate. All right. I'm going to say DL versus VL. How about
Totally
that?
acceptable. Totally acceptable.
So who wants to kind of tell us about the new generation of learners and the technique of VL?
I'm happy to take that one, Karen. So, the direct laryngoscopy, the blades are an old technology. The Miller blades, which is the straight blade, has probably been around since the 1920s. The curved blade has been around since the 1940s, and we're no longer in the 1900s, right? We are in the 2000s, and we're still using a fairly old technology. if we look at our learners right now, and this is really, I think, where one of the cases is for VL, for that's the modern way we should be teaching laryngoscopy. When you use a standard DL and you have a learner, the learner is the only one looking at the airway. They're the only ones that see the vocal cords. And the preceptor is saying, what do you see? What do you see? Or the surgeon is saying, what do you see? What do you see? What do you see? And nobody is seeing. So nobody can kind of guide them, especially when they're learning about what looks right, what doesn't, how you can adjust. And the only person who's seeing what you're doing is you. However, when you use a video scope, everybody in the room can see. So your preceptor, as you're learning, can say, wow, I see what you're seeing, but maybe you should move to the right, or maybe you should move to the left, or maybe you can give real-time guidance. It also works because our new generation of learners, and I can't believe I'm not in that generation anymore because I feel like I'm in that generation.
Don't we all are?
That new generation of learners is very used to gaming, is very used to hand-eye coordination, and that is really where they excel. So you should meet them where they're at. And that's why I think video for teaching and learning purposes is really far superior.
So do you still teach them direct laryngoscopy? Because you may be somewhere where you don't have a video laryngoscopy.
Well, Karen, what do you do in your practice for your...
It's funny that you asked that because after a presentation yesterday, one of the students came up to me and said, I'm really worried that I'm not going to learn how to DL because all we learn is video laryngoscopy. And he didn't realize that with the newer scopes that are not hyperangulated, you can see. So you can use them as a direct laryngoscope and look at the cords without looking at the screen. So you actually can learn both ways with that scope.
Do they have a straight blade on that one?
They're available.
They are available.
But we don't have straight blades. We only have the Max.
I will say for new students, I'll use a video because I want to see what they're seeing. I want to be able to help them. I want to be able to coach them. I think it's important not to lose a DL skill. So you know how robotics, everybody's doing, if the other day we did a robotic anal polyp, which was very weird to me because I don't know why you need a robot, but everybody's on the robot train. But I think what happens, and you've probably seen this in your own practice, Sharon, is people are very used to the robot. So, but then when they need to convert, when they need to open, like they don't know how to do it because they have been so out of practice. And you're right. I hear that argument about, I don't want to lose my DL skill. I can see that argument. So I do like students also to do DL, but I do think there is so much technology coming out that so we lose DL. And, you know, you're going to tell me, you know, we didn't used to use pulse ox, but can you imagine not using pulse ox? We didn't used to use train of form monitoring, but now we do. I just think it's a technology that has evolved now, this VL, to where you can use it as a DL, as Karen said, a non-hyperangulated blade. I just think it's a superior technology.
Well, I love the idea that you talked about because I remember clearly whenever I was a brand new student and they're saying, what do you see? What do you see? What do you see? You don't know what you see. I see stuff. I see stuff. Yeah, exactly. So I can absolutely appreciate the value of what you're saying. Again, I think it's a particular skill that you need. Recently, I had run across an article that says that within 3 weeks, your skills can start deteriorating. Of course, that is relevant to how long you were doing it before. If you've only been doing anesthesia a year, the deterioration comes faster versus somebody like myself who's been doing it a long time. And one of the places I work is an ACT environment, and the ologist and I were talking about it. And he said, oh my God, Sharon, I haven't intubated somebody in a long time. And I go, you're welcome to do it whenever you're in here with me. I don't have any ego about it anymore. So he loves working with me because we'll switch places. And he'll come in and he'll intubate because he's so scared after that whole discussion. But, you know, I worked in an office 16 years. Whenever I went back to a hospital, I had never seen a glide scope. In the very first case I did, as I came back in the hospital, I took one look and I go, this is not happening. And the ologist said, you want the glide scope? And I go, sure. I've never used one.
Sharon, you raise an extremely important point. So we always run to the VL when it's difficult, But VL is a skill. There's some recent article that came out that about experienced anesthesia providers. How many times does it take for them to use a VL to become somewhat competent?
I did it the first time, and he said, well, it looks like you've done it before. I said, well, cords look the same no matter if you're looking straight at them or on a screen, and I've been fine.
But it takes about 12. And the hyper.
Well, then I am absolutely special, and aren't you glad you now know it?
No shock.
One of the things we talked about, Laura, was that I was really resistant to the video laryngoscope. I've been an anesthetist since 1995. I trained
still a baby.
Before. Oh my gosh, I love you. I love you. No one says that. I trained before the video laryngoscope, the first commercially available one. So when the GlideScope came out, it was an event that you took it to your room, and if someone else needed it, they had to hold up their case because you had to stagger. And when we got these little boxes with portable video laryngoscopes in the room, I just said, no, thank you. For years, I just pushed it to the side. And I finally realized that everybody was doing it except me, and got that video laryngoscope out. And it was a whole new ballgame for me, especially peds, OB, out of hospital intubations. Amazing. Totally changed my path.
But they're easy to use. Doesn't take that long to gain competence. However, it shouldn't be something that you've never touched. You should be comfortable.
Not my story, right?
Your story was probably skill and a little bit of luck, right?
So you're saying 12 times and I can do it.
Probably could.
Laura, what happened?
You are now an honorary ANA member, sir. I think you can do anything.
Oh, wow. I like that.
Even though I missed the business meeting this
I didn't
morning.
know I was supposed to be there.
Yeah, well, membership has its privileges and its
hey, you know what?
obligations.
But I also know if I show up somewhere I'm not supposed to be, somebody's going to smack me pretty hard, and might be this one. What the heck are you doing here? You're not supposed to be here. So anyway, really what we're talking about is technology. Technology is changing, and what are the other advancements in anesthesia at the moment that you're seeing?
I'm going to lean heavy on a couple things. Did you know there's a job called a futurist?
Yes.
Job?
It's amazing. I aim one day to be a futurist. So this is somebody who talks about what's possible, take away the barriers and what's possible, and you can do it. And they're really forward thinking.
Does it involve tarot cards?
Maybe there are some futurists who believe in that, but I think we are steadily marching towards technology augmenting us, not replacing us. Some professions, Microsoft just came out with their 10 jobs that are going to be replaced by AI,
right?
And the 10 jobs that are not. CRNAs were not on any of those lists.
Sure.
Healthcare providers were not on any of those lists right now, except maybe radiologists. But I do think AI is going to change the way we do our work.
No doubt.
Absolutely. The way we engage with data, the way we use data, the way we consume it, the way it helps us, but also technology. There's a pilot program right now where there's the phlebotomist who goes out, but it's a robot and will gather blood and send the blood. So, you may not need that job anymore. But the way we embrace the technology and use it in our everyday is going to change fundamentally the way we give anesthesia. Also, I think people are going to get probably a blood test, and it's going to be, this is the drug you can get.
Yes,
this is what your genes say.
That's coming.
You're going to get 200 of fentanyl, but Sharon's going to get 100 of fentanyl because her genes say that she's more responsive.
Right. It's interesting. I was watching something from Meta the other day, and they were talking about AI and the future of AI and how they're not sure how they're going to do it yet, whether it's going to be a wearable or something that every person will have access to every bit of data at any time. So if you're sitting here telling me about VL versus DL, it will be showing me exactly what that is, defining it, how to do it. You'll have this whatever it's going to look like. That is what AI is coming to. And they're saying that if you ask me a question about anything, there's not going to be anything that I won't be able to answer.
Wow.
Which is amazing.
That's a lot of information for your brain to process.
Yes. But it's going to be constant feeding that information. So, technology is changing everything, and AI is definitely going to change everything we touch. It's going to change the way you work as well.
Speaking of AI, Miss Futurist, tell us what you think this is going to look like.
Yeah.
What do I think it's going to look like? Well, I mean, we see it every day now. You know, people who tell me they're scared of AI, you know, my answer is always, do you use a GPS?
Yes.
Do you? I mean, you don't understand how you're interacting with it every day. I do think right now, and we have this in many of our ERs, is the clinical decision support is, you know, there's no reason somebody needs to remember, you know, in an emergency how much amiodarone to give. Like, I see us in the next couple years running a code, and AI is in the background telling us what to give, observing what we're doing in the room and saying, your compressions are not deep enough, not fast enough, patient should be getting X, Y, and Z. You know, for us not to have to remember that stuff because we have cognitive overload right now.
Amen.
That's amazing, though, because does that change the way you teach students? Does it shorten the amount of time that students need to go?
I think it
to residency?
changes the way students learn.
Okay.
Right? So it's the way they consume information. Like, they don't need to probably memorize things, but they need to understand how to search, how to find, how to evaluate data appropriately, how to be a good consumer of the content. And those are different skills.
Oh, absolutely.
Right? That's not how I learned in anesthesia school.
No.
I got a book, memorized it. What's on page 32, paragraph
Morgan
1.
and Mikhail, where is it?
Well, he even knows the lingo, Sharon.
He's good. He's good.
Do you know who's hard to intubate?
you
If they have a
promote?
thick
Oh,
neck,
can.
yeah,
And
yeah.
you would call for a VO.
Yes, absolutely. Absolutely. No doubt.
Well, his wife is a CRNA, and my husband gets tired of this sometimes. Somebody will walk by when we're at dinner, and I'll go, oh, my God, I'd hate to
Hate
put
to
a tube.
intubate that person.
But listen, my 8-year-old twins know it now, too. They're like, Mommy, is that person hard to intubate?
Yeah.
Yes.
They
You're
have no
very
neck,
right.
short jawline.
Yeah,
Oh, yeah.
that skill
Yeah.
does not go away. My anesthesia mom, parenthetically, she wasn't really my mother, but who took me under her wing when I got out of school. In her later years, she had a stroke, and we were sitting in the rest home, and she had expressive aphasia. She called me Marie. She knew clearly who I was, but the wires were all crossed up. And we're sitting there, and this kyphotic lady with a walker goes by the door, and neither Barbara or I said anything, watching the woman clunk by. Barbara hadn't spoken a word, hardly understandable, in 3 years. Swear to God, she turns around and she looks at me and she says, bad airway.
It's innate.
Yeah.
Are you a resident or CRNA looking to transition into independent practice? Introducing the 1099 CRNA Institute, taught by Beyond the Mask host Jeremy Stanley and Sharon Pierce. This comprehensive educational series provides detailed guidance on business structure, legal and tax implications, and financial management tailored specifically for 1099 CRNAs. Enroll now and earn valuable continuing education credits as you chart a new course in your rewarding career. Remember, that's aana.com/1099 or click the link in the description of today's show.
So, is a robot going to be able to replace an anesthetist? I mean, is that where we're going?
What do you think, Karen?
I really hope not, Laura. This all worries me.
Karen, how many more years you got in
Maybe
this field?
15, I'm going to say.
All right,
15 years.
All right.
I'll be okay.
All right.
I probably have 25 at the rate my kids are costing me, or maybe 30. I don't know.
Maybe never.
Listen, I don't think a robot is going to replace us. I think a robot is going to change the scope of our work, to be honest. I think some of the things that can be offloaded will be offloaded smartly so that the CRNA at the head of the bed can concentrate on CRNA things that only we can interpret, evaluate, interact on, and manage. The stuff that's cognitive waste, like maybe the charting and the things like that, like, shouldn't I be able to say in the room, I gave 100 of lidocaine and the chart picks it up, right? An ambient scribe, right? So I don't have to do that. So I can do important things like making complex decisions that a computer can't.
So it's interesting that we're having this discussion because I look at AI and I think, economies of scale, obviously you're doing more with less. So I often wonder, knowing this industry like I know it, could an AI or a robot supervise? And then it takes out of the equation a big cost center for cases?
Well,
because supervision
we need to get him some body armor.
Oh, they're coming for you.
I just wonder. I mean,
Actually,
what does that look like?
Or should we be supervising the AI?
Well, I think we've got some sort of template here, the sedasis monitor.
True.
That was going to give sedation for colonoscopies.
The GI procedures.
Yeah. And that didn't work.
It didn't work,
But
right.
there were ways to override it.
I also think the timing wasn't right.
I agree.
Like that was 10, 12, 15 years ago.
Yeah.
When it began, it had a place. And let me explain that, because a lot of people were doing conscious sedation. There were a lot of deaths along the way, and anesthesia really had not stepped into that market. So when they started it, never was it foreseen that CRNAs were going to own that market going forward. So would I rather have a machine doing it versus a registered nurse who had no real training? And the machine had mechanisms within it. Whenever I was AANA president, I went and I visited where they were making them. And I did share my concerns that it could be overridden. You've got a GI doc going, yes, give some more fentanyl. But they said, well, the machine will only do so much. And I said, listen, we know how it really works. And if the doc is screaming, give more fentanyl, the nurse is going to give it. That's what's going to happen. So, but you're right. It was at the wrong time.
Yeah. I mean, I'm not a futurist. I don't know if it's going to come back, but maybe some version probably will come back, especially as we go forward in the way our workforce is going to change.
So how do I make sure that I'm ready for the next 10 years of practice, that I'm not going to practice 10 more years, just saying?
What do you think, Karen? You want to take a stab at that?
Definitely learn how to use that video laryngoscope.
Yes.
Like I did, for sure.
Ready for the next 10 years of practice. I think you're going to need to adopt a different skill set. I think you need to be media and IT savvy. I think the idea that you have a favorite pen that you pull out your anesthesia chart with is probably going to go the way of the dodo bird.
Well, just think now, you don't even know what the date is, because we used to write it down 15, 20 times a day.
Now you don't. Right.
And I have no idea what the date is. And then I realized it's December.
Well, today I didn't know it was, I thought it was Sunday today, but it's not. It's Monday. But, I think you have to be able to embrace technology over the next 10 years. I think you have to find a way to consume all the data and all the research that is coming in, and you can't do that physically. Physically, you can't read every study that's out, and you can't be up to date with everything. So you have to find a method to do that, whether it's OpenAI or it's open evidence or however it is that you're getting your information. So you have to be ready for it. And I think the most important trait you can have over the next 10 years is embracing change, not being scared of it, being adaptable, being able to pivot, not being stuck in your ways. Because the CRNAs that are coming out now are fundamentally different than how the three of us, I think, trained. Right?
Sure.
They have a different skill set. They respond to things differently. They get educated differently. We saw something about social media that 40 to 50% of people get their news from social media. I mean, it's a very different way that people are engaging. So stay relevant in the next 10 years. You have to be adaptable. You have to be ready to change. You have to be ready to, take on something new.
What's hard about that, though, I mean, I think, as you said, Laura, you get set in your ways, and then you don't want to change. I mean, you wouldn't pick up that little box, remember,
I would not.
Karen?
I would not.
So, and what I find is as people are a little more seasoned, especially anesthesia providers, you are more set in your ways, and then to have to learn new technology,
Let's
new
call
things.
it comfortable.
Yeah, you're
We're
in your
more
comfort zone.
comfortable.
You're in your comfort
Yes.
zone. I know how to do this. I know I've done this 100 times.
And it's worked
I'm
for me every
going to continue to do
time.
this
Yeah.
the same
Yeah.
way.
And you don't want to look like you don't know how to do it.
Right.
I don't want to
Absolutely
learn a new
not.
blade in front of people. They'll think I don't know how to intubate.
Right.
I'm a senior.
And that type A personality of CRNAs does not want to do that, right?
No.
Well, I think that's going to change. We did a podcast with Aaron Martin talking about the students post-COVID, and they they lived through COVID as ICU nurses. Everything was different every single day that was coming out. And they're finding that they are super flexible because that's how they had to live through COVID. And that makes perfect sense. So maybe they'll change that little quirk in our profession.
Listen, we're wedded to that for a good reason, right?
Oh, yeah.
We want to be safe. We know it works. It's tried and true. It's reliable. Nobody wants it. You know, in industry, you can take big risks and you can fail because it's not a big deal. You're not going to hurt somebody.
Right.
We take a risk and we might hurt somebody. None of us comes to work wanting to hurt somebody. So it's very hard for us to take risks and be adaptable.
Yeah, I don't know if I agree with you. I think some of your cohorts probably want to hurt somebody when they come to work. But anyway, hopefully not the patients, right? So.
Each other.
Colleagues.
Listen.
Podcast hosts.
That's right, podcast hosts. So, obviously, I mean, these things probably aren't cheap and changing and so forth. What do you do if you work at a facility that says, we can't afford to do this? We don't have the money, or...
You mean like, Laura, we need to spend money on Sugamidex or a new anesthesia machine. Get out of here. Your DL works just fine.
Right. Sounds like you might have heard that.
Yeah. What do you think, Karen? What do you think they should
Laura,
say?
this is your area of expertise. I am not even talking about this. This is where you shine, girl. Go for it.
All right. This is my bean counter so that you can talk to your administrators. So I will absolutely submit to you that the upfront cost of a DL head-to-head with a VL, DL is much cheaper, right?
Even though now they have you throw the blades away because it costs more to clean them than it does just to buy another one.
Disposable direct
Crazy.
laryngoscopy is what most of us are using, right?
These are not disposables. These are metal. Like
the metal that you can recycle. I hope you're recycling. You can have me on about another.
They are throwing them away.
Oh, that's sustainability is another thing near and dear to my heart.
Wonder if I should start keeping them and gassing them and sending them on to medical mission places. I need to talk to Jackie about that.
You could. Or many of the companies will take them back and give you a preferred pricing when you buy back recycled ones.
Learning something new every day.
The upfront cost, of course, is much lower for your disposable DLs than your VL. Absolutely, I get it. And over a 5-year cost analysis, it's still more expensive. But when you add in, so first pass success, right? We want to get the tube in and be done. We don't want 10, 15 minutes of a delay. You don't want an airway complication that Karen sees all the time with her. Ask her to go through her pictures. They're really horrifying, and they cost a lot of money.
No.
But over time with delays, like you couldn't get the intubation, so you change a blade, right? That's another $10. And then you can't get it with that second blade, so you change to a video scope, and that's another $15, $20. Now you've wasted 15 minutes of time at $110 a minute. That's about $1,500. And then you've wasted $40 in additional blades. So if you do that, even if it's just, over 5 years, maybe you do 5,000 intubations in your institution. That's about 700 or 800 times that you're changing blades, wasting time. That's a lot of money.
A lot of money.
If you did VL first pass every time, you would be saving all that money. So over the long run, I think it saves you about $1 million over 5 years for a moderate-sized hospital. Because if you add in that time of delay, 15 minutes, extra blades, maybe even a major complication, like the patient stays another day or two, or the patient spends more time in the OR because they're hypoxic and they don't feel so well afterwards. All that adds up. So first pass success, I think, is really important, and I think that's far superior with VL versus DL.
So tell me some of your stories. Everybody's got stories to tell where maybe the VL has helped your practice outside of saving $1 million.
Well, when I finally picked it up and used it,
How long was that transition there?
She started kicking it aside.
A minute, literally. I started using it in peds.
Okay.
Because I do OB, I do peds, I do adults. And, I used to think the smaller a person was, the easier they were to intubate. And then I met infants.
Sure.
They are challenging. And I used it first on children. And I love a Mac blade. And although it's available in the Miller, we don't have those. So having a 1 and a 2 Mac for kids was a dream for me. Made it so easy. And, the new guidelines for neonates and infants less than 1 is that we use video laryngoscopy first and every time, and putting that blade in, getting a great view, decreasing airway complications. Decreasing edema for them. Any trauma in small people is significant. And that makes a big difference for them because you can end up with, post-op complications from the intubation and permanent injuries. So peds for sure. OB, I do a lot of OB.
Be very applicable in OB.
We hope to use neuraxial, but we do general like 6% of the time. And they are always, they're swollen. They bleed
everywhere.
Easily. They just saturate like stones. If you're doing rapid sequence because it's an emergency, you're already starting to saturate before you even put the blade in. So being able to get that good view and that easy intubation has made a huge difference in my stress level and obviously patient care.
Another thing I suppose it would be helpful in, because I have done a DL on patients. I'm like, what's that hanging over their vocal cords? You've got to come and look at this.
Yes.
If you could take a picture.
Yes. Yes. That's the future.
That would be helpful.
The future, yeah. A lot of patients we don't realize have pre-existing injuries that they may not be diagnosed. We were talking about Reinke's edema, which is what causes that deep throaty smoker's voice. And it's actually chronically edematous vocal cords. It has like a jelly-like substance in there that makes them big and ugly. And patients don't get diagnosed because it's slow. It comes over years of irritation. They show up to us and we intubate them. We take a look and they've got these giant vocal cords. There's not a lot of room for an endotube and a lot of injuries to patients with Reinke's edema. So being able to see that or see like a pre-existing hemorrhage or a polyp or something like that.
Let's talk about something else that's near and dear to my heart. I do a lot of legal work. So can you imagine a time where before we intubate, we take a picture of the cords, we intubate, and then after we take it out, we take a picture and we put that in the chart?
I could see that happening.
Right? To say that we haven't caused any damage. Instead of us writing in the chart, smooth VL, nothing happened, no untoward events, right? Like if we could get a snapshot or even a video embedded into the EHR of your intubation to kind of do a CYA, but also, full transparency. This is what happened. That's also the way I think, AI and technology can help us.
So lawyer, futurist, CRNA, what else you got
my
in that
mom
bag?
Mom is most important.
Mom.
That's
Oh,
the
yeah,
most
of course.
important
That's most
title.
important. Yeah. Well, this is interesting. Obviously, I don't know a whole lot about it, but I can see where this has, great potential. And Sharon, are you going to try and use a VL now?
Oh, well, I do, but I do it in select cases because, again, I don't want to lose those skills that I've culminated in many, many years. And I'm pretty doggone skillful after all these years. It's interesting because I am in an ACT in a couple of places that I work. I work by myself a lot of times too, but they'll say, man, I didn't think you'd be able to do that. But it just comes from years and years. And it also comes from years of having no other way. If I would have to use a bougie. I worked in offices for 16 years. And I could throw a bougie in somebody, fill the tracheal rings, thread the endotracheal tube. And now that gives me hurts the coronaries a little bit now that I know that I've got other options. But that was the only options that we had.
I agree. I love to intubate.
Yeah.
I don't want to go to VL 100% of the time because I still love to intubate. And I don't have to. I can do a little of both.
Yeah. I want to try the little handheld thing. Now you're making me want to try it. I know we've got one in the department. I just need to find it.
It's amazing. I literally used it a couple times in kids and was like, why did I ignore this for so long? It's amazing.
But if our skills deteriorate in just a mere matter of weeks, that still is in the back of my mind. And if you've not developed that skill, and not everywhere I've intubated has been easy. Now, when I was in school, they used to put us in difficult situations on purpose. They would make us intubate with our fingers or a tongue blade, or whenever they come down from ICU, they wouldn't allow us to move the patient up in the bed or take the head of the bed off and make
to get
us,
your skills where you work.
Yes. I could intubate with a whistle on the end of a endotracheal tube, and it really looked cool. You really look cool.
Sharon, one of these days, there's going to be a power outage. No one will be able to find the video laryngoscope. You and I are going to run in with our DL, our flashlight, and save the day. And we're going to be proud of it. Yes.
Right. We've had all kinds of good conversation today. So as we wrap this one up, anything you guys would like to conclude on?
Give it a try.
Yeah?
Give it a try a few times. Yeah.
Yeah, give it a try. I think you have to be comfortable with it, too.
Yeah.
If you're unlike the superstar Sharon, the first time you pick it up, it might be, it's different. Some of them you need a stylet. You always get a good view. It's getting the tube in, and that takes a little bit of practice. So be comfortable with it.
Can make a big difference for patients. Injuries are life-changing for them, and having this skill is invaluable.
Well, and I think that's pretty much it. Save money, better patient outcomes. Sounds like a great opportunity. Laura, maybe you could go sell these things at some point too, and just add that to your list.
Yeah, that's my list.
All right. Well, thank you both for being on, and we really appreciate it. Wonderful news for our listeners and CRNA community who maybe not have taken up this skill set, but will in the future. So, Sharon, I think it's a wrap.
I think it is.
Thank you for tuning in to Beyond the Mask. If you enjoy the show and want to help us grow, the best way to support us is simple. Leave a review on your favorite podcast platform, share the show on social media, and tell your friends. Your word of mouth is what keeps us going strong. We're proud to consistently rank in the top 50 medical podcasts nationwide and to be #1 in the CRNA community. All thanks to listeners like you. Your support helps us stay there, and we couldn't do it without you. We'll see you on the next Beyond the Mask.